Welcome to Case Studies in Obstructive Sleep Apnea. Importance of Early Identification and Treatment. This program is part of the Antidote Continuum of Learning. Educational support for this activity has been provided by Cephalon. Throughout this presentation, you will be asked to answer questions. Please take a moment to consider each question and select the most appropriate answer. The correct answer will then be shown along with an explanation. Dr. Paul P. Doghramji is co-founder of Brookside Family Practice and Pediatrics, a current affiliate of Pottstown Medical Specialists in Pottstown, Pennsylvania. He has also been attending physician in family practice, chair of the Utilization Management Committee, and physician advisor at Pottstown Memorial Medical Center. Most recently, he has moved his practice location to Collegeville Family Practice in Collegeville, Pennsylvania. Dr. Doghramji is a fellow of the American Academy of Family Physicians, a member of the National Headache Foundation and Chronic Fatigue and Immune Dysfunction Syndrome Association. Dr. Doghramji's work on sleep medicine has been published in Postgraduate Medicine, the Journal of Clinical Psychiatry, InSom Magazine, and the International Journal of Clinical Practice. He is co-author of the textbook entitled Clinical Management of Insomnia, released January 2007.
Learning objectives. This is to recognize the symptoms of a drowsy patient, which is excessive sleepiness and its causes, identify individuals who are at particular risk for obstructive sleep apnea, compare the effectiveness of polysomnography with that of other tools used to diagnose obstructive sleep apnea, prescribe treatment, including behavioral therapy, pharmacologic agents, and continuous positive airway pressure, CPAP, for patients who have OSA, support patients through treatment to ensure correction of underlying sleep deficits. Let's first talk about the patient coming in with tiredness. Patients will come to you complaining, I'm tired all the time. I have no energy. I'm fatigued. I'm depressed. I don't feel rested. I can't sleep well. All of these may possibly mean that the patient has excessive sleepiness. They may oftentimes also say to you vague complaints like, I'm in a fog, or my partner says that there's something wrong with me. So let's tease apart what it means when a patient says, I'm tired. Patients may mean that they're sleepy, which means that there's a higher tendency for them to fall asleep when they shouldn't be falling asleep. Somebody in the early afternoon, late afternoon should not really be sleepy. And what makes sleepiness better, what makes the tiredness that is sleepiness get better, is sleeping. Patients who are tired may also mean that they're fatigued. Now, this is different. This is a sensation of weariness, exhaustion, lack of energy, lack of stamina. And what makes this better is resting. An example is if you were to work out for about an hour and a half or 2 hours, you wouldn't be sleepy, but you would be fatigued. You would need rest and not sleep. Again, patients will complain of tiredness when they're sleepy as well as when they're fatigued, so we have to tease this apart. What complicates it more is that patients who are depressed, lacking in motivation, may also say, hey doc, I'm tired. So let's keep in mind that when a patient says they're tired, what we have to ask them is, are you sleepy, are you lacking in energy, and are you fatigued, or are you lacking in motivation? There are many conditions associated with sleepiness. Obstructive sleep apnea tops the list with between 3 to 28%. Other things, however, like shift work sleep disorder, insufficient sleep syndrome, comorbid insomnias, restless leg syndrome, and narcolepsy. These are all conditions that can present with excessive sleepiness. The prevalence of excessive sleepiness in the population may surprise you. The National Sleep Foundation does polls every year to find out how we're sleeping. And this year they completed a poll asking patients, how sleepy are you throughout the day? And 28% said that they're so sleepy that it interferes with their lives a few days per month. And about 13% said that they were so sleepy that it interfered with their lives a few days per week. So it's out there, substantial amount of patients with excessive sleepiness. Now, when we carry this over to the remainder of the world, they're no different. So excessive sleepiness isn't a problem that we Americans have. When we look at other countries, they have pretty much the same statistic, anywhere from 10 to 13% of patients having substantial amount of sleepiness. So, all right, a lot of patients are sleepy. There's a substantial amount of Americans who are tired. So why should we ask about it? Well, for one thing, there are a lot of accidents and injuries and even deaths attributable directly to being drowsy. You can already tell that a drowsy person is going to get into more car accidents, and we're going to discuss this further. But more than $100 billion per year are attributable to accidents that can be prevented in patients who are excessively sleepy. When patients are drowsy, not only are they more dangerous, but they also are not feeling well throughout the day. We have data here that suggests that patients who are sleepy have more problems with their relationships. They have more problems in their occupation. They don't feel well. Their physical well-being or even psychological well-being is definitely impaired. Patients who are sleepy just don't feel well. Now, an interesting study that was done to ascertain the degree of sleepiness and its effect on driving was just conducted a couple of years ago. Medical residents were sequestered, and after a night call, they were given a driving test, a driving simulation test. Now, there are 4 parts to this, where one part, they had a light night call, and they took the driving test. Then they had a very heavy night call, and they took a driving test. Then after a light night call, they were given alcohol to the point of getting them drunk, and they were given the driving test. And finally, after a heavy night call, and giving them placebo, making them think maybe that they had had some alcohol. And the data was quite surprising, that patients who had the heavy night call were actually more likely to make mistakes than those who actually were legally drunk. But the interesting difference was that those who were drowsy and they knew that they weren't driving had a higher level of awareness that they weren't driving well. That is, those who are drunk will think that they're driving well even though they're not. Take-home message: to be drowsy and driving is at least as bad as being drunk. Now, with specific reference to sleepiness and obstructive sleep apnea patients, what we find is that close to $16 billion a year are attributed to accidents and injuries and problems from these types of patients. Also, 1,400 deaths per year, 800,000 accidents. So specifically with sleepiness and obstructive sleep apnea and driving, a substantial problem when it comes to driving. Now let's define obstructive sleep apnea. OSA is defined as repetitive episodes of complete or partial upper airway obstruction during sleep. Now, this is measured via an apnea-hypopnea index, or AHI, which is the average number of apnea-hypopneas per hour. Now, an apnea is defined as a cessation of airflow for at least 10 seconds. Hypopnea, on the other hand, is partial obstruction that is either severe enough and or causes desaturation and or arousal. So the diagnostic criteria of OSA are excessive sleepiness or related symptoms, or sleep interrupted by gasping or choking, or loud snoring, so 1, 2, or 3, and either AHI, apnea-hypopnea index, equal to or greater than 5, and lack of better explanation for the disorder. Now, an alternative diagnostic criteria for OSA, an apnea-hypopnea index equal to or greater than 15, and lack of better explanation for the disorder. So the difference between these two criteria are that in the second one, it's basically only on the apnea-hypopnea index and not really looking at any symptoms of excessive sleepiness or choking or gasping or snoring. So what's the prevalence of obstructive sleep apnea? Well, interestingly, about 18 million Americans experience obstructive sleep apnea. It is estimated that 1 in 5 adults has at least mild OSA, that 1 in 15 adults has at least moderate OSA. Also, if we use the criteria of an AHI greater than 5 and excessive sleepiness, this would be about 2% in women and 4% in men. But if we take away the excessive sleepiness symptom and just go by an AHI greater than 5, then the criteria would fit 9% of women and 24% of men. Now, interestingly, in 1997, it was estimated that up to 93% of women and 82% of men who had moderate to severe obstructive sleep apnea remain clinically undiagnosed. Take-home message: the condition is extremely common, but yet we're not doing as good of a job as identifying the condition. This slide shows graphically what's going on with a patient with obstructive sleep apnea. Now, this suggests that there's an anatomical obstruction, but let's keep in mind that there is also a substantial amount of physiological obstruction. That is, when we look at the throat, we can see a patent airway. However, when the patient is sleeping, because of relaxation of musculature and because of decreased reflex action from the soft palate to the pharynx, there may be collapse that's purely physiologic and not anatomic.